Let's jump right into it. Welcome to The Explainer. I'm your host, Herschel, and today we're diving into this incredibly fascinating dual reality in healthcare. On one side, you've got the intense, high-stakes, life-or-death environment of the ER, and on the other, the highly precise, literally down-to-the-letter administrative work of translating those intense interventions into accurate ICD-10 codes. It's like a giant puzzle. So here's our quick roadmap for today's explainer. We're going to look at emergency red flags, the status epilepticus protocol, how to actually code status epilepticus accurately, sepsis recognition and bundles, and finally, mastering those tricky sepsis codes. All right, part 1, emergency red flags. Let's get into it. In the emergency department, a red flag isn't just some clever metaphor. It is a literal trigger in triage systems. Think the emergency severity index that screams, hey, initiate priority resuscitation right now. It's a massive warning sign signaling the imminent failure of a patient's cardiovascular, respiratory, or neurological systems.
So what exactly are we looking for? Well, unstable vitals. We're talking severe hypotension, where the systolic drops below 90, or the extreme opposite, right? Severe hypertension shooting above 180. We're keeping an eye out for bradycardia, plummeting below 40 beats per minute, or tachycardia racing above 150, agonal respirations, or a Glasgow coma score dropping below 8. Now, if you're a medical coder, listen up, because these are the exact clinical signs you must actively hunt for in the provider notes to firmly justify a critical condition.
Moving right along to part 2, status epilepticus, the protocol. Okay, the absolutely crucial metric you need to remember here is the 5-minute mark. Basically, a continuous seizure lasting more than 5 minutes, or repeated seizures without any recovery in between. That 5-minute threshold, it's a total game changer. Once that line is crossed, the clinical team instantly shifts from basic observation to aggressive, life-saving intervention. Because what's actually happening during these continuous seizures is a chaotic electrical storm, literally raging inside the brain. And without immediate medical suppression to calm that storm down, this uncontrolled electrical activity can lead to permanent, devastating neurological damage. Time is brain here, guys. So to stop this storm, providers execute a super strict 3-tier protocol. Step 1, the first-line therapy, is benzodiazepines administered in under 5 minutes. If that doesn't work, boom, they quickly escalate to Step 2, deploying second-line anti-seizure drugs, or AEDs, right around the 10 to 20-minute mark. Finally, if the patient is still seizing, which we call refractory status epilepticus, they move to Step 3, bringing in powerful intravenous anesthetic agents. Okay, part 3, coding status epilepticus accurately. Now, on the administrative side, your coding essentially has to mirror the exact precision of that clinical protocol. When you're looking at status epilepticus, you absolutely cannot just code seizure. No way. You are required to explicitly document the exact seizure type. You've got to note its intractility, meaning, hey, was it actually responding to those Tier 1 and Tier 2 drugs we just talked about? You also need to pinpoint the underlying cause and clearly differentiate whether it's traumatic or non-traumatic. Literally, every single detail matters for compliance. And because these rules are so incredibly strict, coders have to be highly vigilant about some really common pitfalls. The absolute biggest trap, defaulting to unspecified codes. Another massive one is failing to explicitly document the seizure's duration. Remember that 5-minute rule? If a provider just scribbles prolonged seizure but doesn't give you the exact minutes, well, you might completely misclassify its severity and intractability. Always, always push for those specific metrics. All right, shifting gears to part 4, sepsis, recognition and bundles. So, sepsis. What usually starts off as a local, relatively contained bacterial infection can suddenly trigger a massive, totally dysregulated immune response. And when that happens, it spreads like wildfire, rapidly progressing into a severe, widespread bloodstream infection with major multi-organ involvement. To properly manage and code this beast, you absolutely have to understand the clinical progression. Sepsis itself is defined as an infection coupled with organ dysfunction. But septic shock, that takes it to a whole different, highly fatal level. Septic shock is sepsis plus persistent hypotension, dangerously low blood pressure, and high lactate levels, which means totally inadequate tissue perfusion. Because this moves so incredibly fast, clinical management is all about early recognition and a highly coordinated 3-hour bundle. Providers have to use validated tools like SARS or Muse to catch it early. Then the clock starts ticking. The protocol is strict. Administer 30 milliliters per kilogram of IV crystalloids within the first 3 hours. At the same time, they've got to push early broad-spectrum antibiotics immediately and be completely ready to use vasopressors if that persistent hypotension kicks in. It is a wildly fast-paced environment. Which brings us to Part 5, Mastering Sepsis ICD-10 Codes. For coding compliance, consider this your ultimate cheat sheet. For baseline sepsis, you're looking at the A40 to A41 range, where you have to code the specific organism and the site of the infection. But the moment the patient hits acute organ dysfunction, we upgrade to severe sepsis, and you must add the code R65.20. And if their blood pressure bottoms out and they fall into septic shock, you've got to use that organism code from A40 to A41 plus R65.21. That specific sequence, organism, then severity, is absolutely non-negotiable. Now here is the golden rule, the absolute bottom line for coding sepsis. No assumptions allowed. Seriously. Even if you see a provider perfectly executing that 3-hour bundle, giving the 30 milliliters per kilo of fluids, pushing the early antibiotics, if they do not explicitly write the word sepsis in their notes, you cannot code it as sepsis. Making inferences is completely forbidden. If the notes are even a little vague, you have to stop and query the provider. So as we process these dual realities today, the chaotic, time-sensitive emergency room on one hand and the hyper-precise, compliance-driven coding desk on the other, I want you to ask yourself, are you catching every single crucial metric? Bridging clinical care to accurate data takes immense attention to detail. Just think about it. A single missed minute on a chart for a seizure or a vague note about fluids for sepsis completely alters the patient's documented reality. Because ultimately, understanding the deep clinical mechanics behind these codes is exactly what makes you exceptional at your job. As healthcare continues to evolve, navigating the gap between the chaotic ER floor and the precise coding desk is only going to get more challenging. So the question is, will your documentation stand up to the pressure? Thank you so much for joining me for this explainer. Keep your eyes peeled for those red flags, and always remember to decode healthcare with Harshal.